Hi, I'm Sugarbaker, treasurer for NISAP. I'm going to be walking you through the approach to the collapsed athlete with suspected cardiopulmonary arrest. In terms of disclosures, this presentation is not endorsed or approved by the AHA or any other professional, medical, or sports training related organization. This is purely a review of literature, kind of responding to some questions we received in our last BLS training session. This video is a good example of cardiac arrest on the volleyball court as well as on the ice, showing some good responses to downed individuals who are found to be in cardiac arrest. You can see these frightening medical emergencies were caught in response to the cardiac arrest, and they ended up having good outcomes. And this is why we care, because people were trained and they knew the steps to take and saved lives. These frightening medical emergencies were caught on camera. During a 2016 high school volleyball game, one of the players suddenly collapsed. You can hear when she hit the hardwood floor. The teen was in full cardiac arrest, so a coach performed CPR. Then school administrator Julie Sermons rushed in with the defibrillator.
Life started to come back in her, and it was wonderful to see.
I had pain down my left arm, and my heart felt like it was working really hard, but I just assumed I was out of shape.
We were just desperately praying. It was 4.5 minutes. I mean, it was a long time to watch them doing compressions, and definitely we thought we'd lost her.
Feel good, better than before.
In 2019, this friendly pickup hockey game suddenly turned when one of the players collapsed from a massive heart attack. A player from the opposing team then took charge.
If he did not receive immediate attention, he probably would not be with us right now.
As luck would have it, he was an emergency room physician.
Yes, he's been here. Yeah. We administered that shock and administered a little bit more CPR for another 1.5 minutes, and he started breathing on his own.
The guys were skating, the EMS guys, out at full speed, hanging onto their arms. I was looking up at Dr. Bryant and first responder EMS guy that was in the ambulance, and I had my hockey gear on and 2 unmatching socks, so I didn't know I was going to be going for an ambulance right that day. The chances of having a cardiac arrest, but having it 10 yards away from an emergency room doctor in an ice rink that's equipped with a defibrillator, I'm a blessed man, and I'm very, very lucky.
So just some definitions. Sudden cardiac arrest is the cessation of the heart's ability to contract and pump blood to the body and brain. All your tissues need blood, and when they don't get it, they die. And this leads to death, permanent disability, if not treated within minutes. You need to intervene to restore the heart's function back. And sudden cardiac death is death due to sudden cardiac arrest. BLS is providing CPR, cardiopulmonary resuscitation, to try and do the heart's job for it. You compress the chest and push blood out of the heart to the body and try to retain some semblance of circulation. And then defibrillation is applying that electric shock to the heart to try to restore that rhythm to get the heart pumping effectively again. Here are some terms, abbreviations, just so there's no confusion going forward. Taking a look at the epidemiology of sudden cardiac arrest in youth athletes. One study we identified looked at sudden cardiac arrest and sudden cardiac death in athletes in the United States from 2014 to 2018. For high school athletes, they found an incidence of 1.5 per 100,000 athlete years, and that's just saying that for every 100,000 athletes over the course of a year, 1.5 of them had one incidence of sudden cardiac arrest or sudden cardiac death. For college athletes, it was 1.9 per 100,000 athlete years. Another study we identified looked at UK soccer players with a mean age of 16.4 years. So around high school age, they found an incidence of sudden cardiac death of around 6.8 per 100,000 athlete years. Finally, we looked at a study in Minnesota. They looked at youth athletes aged 12 to 19. They found an incidence of 0.24 per 100,000 athlete years. So incidence varies per region, population base, but all around very rare. Sudden cardiac arrest and sudden cardiac death are very rare in youth athletes. Studies identified a 10-fold lower risk incidence in women than in men, and that's across all age groups. There's a higher incidence of sudden cardiac arrest, sudden cardiac death in Black or African American NCAA college athletes. So to conclude, we can see that sudden cardiac arrest and sudden cardiac death is a rare phenomenon, but it is catastrophic. Recognizing and intervening can save lives and prevent lasting disability. So for the etiology of sudden cardiac arrest in youth athletes, etiology meaning like what are the fundamental causes of sudden cardiac arrest? There are many structural abnormalities. So these are congenital abnormalities from birth, or they can be acquired, like hypertrophic obstructive cardiomyopathy, problems with the coronary arteries that feed the heart muscle itself. You can have fibrotic tissue in the heart, and you can have inflammation in the heart, myocarditis that leads to cardiac arrest. Electrical abnormalities are not uncommon in the pediatric population, like long QT syndrome, Wolff-Parkinson-White syndrome, Brugada. These are all conduction abnormalities that can predispose to rhythms that are incompatible with life, like ventricular tachycardia or ventricular fibrillation. And then some individuals can be born with a condition that gives them high cholesterol in their blood. So at a very young age, they're at risk for heart attack or myocardial infarction, where these plaques block the coronary arteries and then blood can't get to the heart, and then the heart muscle dies, and that causes cardiac arrest. Blunt force trauma to the chest. It's a condition called commotio cordis, where you get a blunt force trauma to the chest at a specific vulnerable point in the cardiac conduction cycle that leads to a rhythm incompatible with life, cardiac arrest. Other sources of cardiac arrest could be lightning strikes, where the electrical discharge messes with the electrical conduction cycle in the heart and causes cardiac arrest, and usually that's a mass casualty incident, which is very unfortunate. Performance-enhancing drugs and stimulant use, so high caffeine, other stimulants that kids, high schoolers might use to get an edge on the field, can also predispose to cardiac arrest as well. And it's important to note that any child, any age, any gender, any sport, any time of year, they're all at risk. It doesn't matter if it's a previously healthy young girl, still at risk. Best player on the team looks to be fit, also at risk. You can't really eliminate anybody from being at risk of cardiac arrest. In terms of recognizing cardiac arrest, it's arguably the most important step in the BLS algorithm, especially in youth sports, where it may not be obvious that somebody's in cardiac arrest, or it's super uncommon, so nobody thinks of it. I remember a story where there was a kid up to bat in a baseball field, and a pitch hit him in the chest, but nobody really saw it. They thought he got hit in the head, and he went down, and people thought he was concussed. Nobody thought to check his pulse. In fact, the ball had hit his chest, and he was in cardiac arrest from commotio cordis. And unfortunately, there was a poor outcome there. So again, recognizing sudden cardiac arrest is very important. So your first step always is to make sure the scene is safe. Once you do that, you want to check responsiveness of the victim. This player just went down. You ran over to him. You give him a sternal rub, pinch his trapezius, yell his name. He doesn't respond. In this instance, you would immediately activate emergency medical response, yell for someone to call 911, yell for someone to get the AED. You would particularly be concerned for sudden cardiac arrest if it was a sudden collapse in the absence of physical contact. Could be a lot of things, but sudden cardiac arrest should be high in your differential for the sudden collapse of a victim without any physical contact. And that's not to say that you should rule out sudden cardiac arrest in someone with physical contact, as we just discussed, commotio cordis. That's a direct result of physical contact, blunt force trauma. So that should, just because they got hit doesn't mean they're not in cardiac arrest. Once EMS is activated, you want to do your carotid pulse check and breathing check for at least 5, no more than 10 seconds. If you're unsure of a pulse and or breathing at 10 seconds, initiate CPR. If there's any doubt in your mind, you're not sure if you can feel it, if it hits 10 seconds, start CPR. You're also to ignore any seizure-like activity or myoclonic jerks, agonal breathing. So people go down in cardiac arrest, they can have involuntary jerking motions, seizure-like activity, and also agonal breathing, where they might take these long, weird, deep breaths that are very spaced and paused out and bizarre looking. They do not resemble normal breathing. You should take that as a sign that the patient's in cardiac arrest, and you should initiate CPR. And a lot of the time, this is a reason why people might delay CPR. They see this jerking motions and this weird breathing, and they think the patient's alive when in fact they're in cardiac arrest. So that's something in one of the next slides we're going to take a look at, is examples of these agonal breaths and seizure-like activity.
Gasping or agonal breathing is not true breathing. Do not confuse it with normal breathing. The victim is in cardiac arrest. There may be seizures. The intervals between breaths get increasingly longer. Start CPR immediately as if the person was not breathing.
This slide just highlights the importance of the AED. Studies show that AED availability and use within 3 to 5 minutes of the initial arrest has been identified as one of the most effective interventions for cardiac arrest. And the greatest determinant of survival after cardiac arrest is the time from collapse to defibrillation. Survival rates decline 7 to 10% per minute for every minute lost. So in conclusion, know where the AED is, know how to use it. If someone goes down, immediately summon somebody to grab it. And get those pads on quickly and defibrillate as soon as possible. This slide is just a review of everything we've talked about regards to the BLS algorithm endorsed by the AHA. So scene safety, check responsiveness, ignore that seizure-like activity, agonal breathing, activate the emergency response system. You get the AED, you call 911. It's important to call specific people out to accomplish these tasks to mitigate the bystander effect. You're going to do your pulse breathing check. Again, ignore the seizure-like activity, agonal breathing. If you're not sure at 10 seconds, initiate that CPR. And you're going to do your 100 to 120 compressions per minute rate. Adult, your compression to ventilation ratio is 30 to 2. Pediatric, with if it's you and another person, it's going to be 15 to 2. If it's just you by yourself, 30 to 2. And you want to defibrillate promptly, ideally within 3 to 5 minutes. This is a great video from the University of Washington's sports cardiology department, highlighting the importance of recognizing and intervening in sudden cardiac arrest in the athletic population.
Hi everyone, I'm John Dresner, Director of the UW Medicine Center for Sports Cardiology, and in the next 100 seconds, I want to show you how to recognize sudden cardiac arrest in an athlete.
He can be seen coming out of a timeout huddle, his head dropping. He stumbles, then alarmingly, he falls face first.
Here you see Keontae, head drop, stumble, sudden collapse. This is what sudden cardiac arrest in an athlete looks like.
And collapses, just like Hamlin did, in sports from football to lacrosse to baseball.
In Mark Vivian Foe, he shows all the signs of sudden cardiac arrest, continued breathing after collapse, eyes open and rolled back, the face of sudden cardiac arrest. For DeMar, after his arrest, his arms go up with seizure-like activity. And for Christian Erickson, a sudden collapse, also unresponsive, eyes open, brief seizure activity in his leg. This is sudden cardiac arrest.
We've been there, but that's not a good look at all.
With Claire, a dramatic episode, collapse with seizure-like activity in the arms, an amazing emergency response. Call for help, someone go get the AED. Remember, in a collapsed athlete that is unresponsive to verbal stimuli and a shoulder tap, you must assume it's sudden cardiac arrest. Call for help, start chest compressions, get the AED. Anyone can save a life.
So a question we received at our last BLS training course was, what do we do if we're on the ice and a player goes down, cardiac arrest, we've already identified it. Do we remove the chest pads and the helmet to initiate BLS? So neither the AHA nor the National Athletic Trainers Association provide clear guidelines on removal of pads and or helmet for the initiation of BLS. And this is a concern because any player who goes down, if they fall over, if they're in some sort of collision, they're presumed to have a cervical spine injury until proven otherwise. And the cervical spine is the spinal vertebrae that are in your neck. So this is important because further manipulation of the cervical spine after an initial injury can cause further damage that leads to paralysis and further disability. So it's very important after an injury that the cervical spine injury is ruled out, and you want to limit any manipulation of the neck at all if a patient goes down due to trauma or they fall over. And usually if someone is in cardiac arrest, they're going to fall down. So that's a very big concern. So on our literature review, we found that the National Athletic Trainers Association has some consensus guidelines geared more towards trained medical personnel on this subject. The exact wording is vague, but they recommend that the face mask should be opened, but helmet not removed to deliver adequate ventilations. And the chest pads should be separated or cut away to give CPR and to put on the defibrillator pads. Other independent studies, and these are not like guidelines or anything, these are just studies that kind of just evaluated what is the effectiveness of CPR on patients with pads on. And so what they did is they compared the delivery, the depth, the rate, effectiveness of CPR on patients with shoulder pads on, helmets on, versus patients with helmets and shoulder pads removed. They found that the compression, depth, time lost off the chest, etc., was improved after shoulder pads and helmet were removed. So they recommend removing shoulder pads and helmet in their conclusions. But again, these are not guidelines. These are just studies kind of looking at these situations. So our conclusion is that you should use your best judgment. As I said, there's no overarching guidelines on this scenario, especially for layperson CPR, that is, people who aren't trained in any medical profession. So if possible, defer to medical personnel on scene. If they respond first with you, they can make that call. If it's just you or another coach, and you need to get on the chest, you've identified cardiopulmonary arrest in the patient, it is okay to splay or cut away the shoulder pads if obstructing compressions and or AED pad placements. You can cut away the pads in the shirt with scissors. You can like untie them, open them up, depends on what sport. And again, those studies show that was associated with increased depths of compression and better CPR overall. And try to remove or splay them with minimal disturbance to the neck. With regard to the mask and chin strap, there's no real guidance on removing the helmet, but removing the mask and chin strap, so get that out of the way with minimal disturbance to the neck, so you can effectively deliver ventilations with a bag valve mask or with a mouth-to-mouth mask or a one-way valve mask, and provide those rescue breaths. If the player is downed, you got to confirm sudden cardiac arrest before consideration of removal of pads and face mask. So if you get there and you feel a pulse and the patient is breathing, do not remove the pads or face mask. As I said, there's a risk for cervical spine injuries, so that needs to be ruled out by a medical professional, especially if there is any head trauma. And what you can do there is just provide manual stabilization of the head and neck as shown in that picture right there. As you can see, the guy is just there holding the head in place, holding the neck stable, kind of as it would be in a normal anatomic position. And if the patient is breathing on their own with a pulse and suspicion for head injury or spine injury, you want to monitor them closely. You want to maintain that manual C-spine stabilization and wait for trained medical personnel, especially if they're complaining of head or neck pain. But if they're unconscious and they're not responsive and they are breathing and have a pulse, they probably got hit in the head, they probably have a concussion, so you want to make sure that cervical spine is okay, and you want to wait for athletic trainer, EMT, paramedic to come take a look. Here are our references. You can look them up and kind of review these papers. Very interesting. an acknowledgement for Peter Sugarbaker, DO, he's sports med doc up in New Jersey. He's my brother. Took a look at this, gave his input, and the whole NISAP team. We want to thank you for listening to this presentation and attending our course. I think it's very important. Coaches, reps, everybody can respond to these kinds of situations effectively and potentially save a life. So thank you.